Good afternoon, dear participant, and welcome to the HIV. Today's topic is gastrointestinal and hepatobiliary manifestation of HIV infection in children. We are honored to have Dr. Sumathi Bhavanandam with us. Dr. Sumathi Bhavanandam is currently holding a position of Assistant Professor Pediatric Gastroenterology at Institute of Child Health and Hospital for Children, Madras Medical College, Chennai. She has completed DCH and MD Pediatrics from Institute of Child Health and Hospital for Children, Madras Medical College. She is Super Specialist DM Gastro from Stanley Medical College, Tamil Nadu. She is a recipient of Dr. Kumara Guru Award for Best Outgoing Student in Pediatrics in 1990. She has more than 20 publications in national and international journals. She is an author and co-author with IAP Textbook of Pediatrics. She has attended many national conferences on pediatric and pediatric gastroenterology. She has been reviewer for pediatric GE subchapters in Indian Journal of Practical Pediatrics, Indian Journal of Pediatrics, Journal of Pediatrics Gastroenterology and Nutrition. Thank you very much, ma'am, for accepting this session. Please, you can take over the session.
Good afternoon, one and all. At the outset, I would like to thank the NACO, iTech India, and Pediatric Centers of Excellence, Chennai, for giving me the opportunity. The next 1 hour, I'll be talking on various gastrointestinal and hepatobiliary manifestations of HIV infection in children. As we all know, children with HIV infection are at high risk of various gastrointestinal and hepatobiliary disease. This is because, unlike adult, in children the main route of transmission is from mother to child. So the gut becomes a primary target organ. Gut is the largest reservoir organ, and various diseases that affect the digestion, absorption, and assimilation can cause malnutrition, stunting, and wasting, which will have a great impact on the outcome of a disease. And GI manifestation can involve any part of GI tract from the mouth to anus. As we all know, increasing incidence of HIV has been noted in Southeast Asia, and this is a matter of concern. There were approximately 35 million people living with HIV at the end of 2013. Now the figure is still more. And 3.2 million people of children were under the age of 15 years, and about 17.6 million children were women and girls. So they are the important source of transmission of infection to children. And each day, every year, nearly 6,000 people are being infected with HIV. So that is a burden of the problem in the community, and more than 4,000 people died from AIDS, mostly because of inadequate access to HIV prevention care and treatment services. So HIV is now become a pandemic disease globally. And the cause of these various manifestations can be due to HIV disease per se, or due to many of the opportunistic infections affecting the gut, the liver, biliary, and the pancreatic system. And apart from that, the drugs we use can cause various manifestations, and last but not the least is a malnutrition that can be the various causes of disease as well as the wasting and the outcome. The clinical presentation may vary from involving the oral tract up to hepatobiliary disease. These children can present with oral involvement, the most common being the fungal infection. They can present with diarrhea. They can just present with unexplained hepatosplenomegaly with or without jaundice, abdominal pain, or they can present with esophageal involvement resulting in dysphagia, odonophagia, vomiting, which further has a compromise on the nutritional aspect of a child. And not GI tuberculosis, another problem which is very rampant in our country, which can cause various disease manifestations. And the infections like cryptosporidiasis, isosporiasis can cause chronic illness in a child, especially with the diarrhea. And nowadays we do have a lot of mesenteric nodes in children with HIV, either due to infections or due to malignancy. And hepatobiliary disease can be presenting as jaundice, ascites, with or without pancreatitis, or with any obstructive jaundice per se. And the clinical symptom of a child with GI manifestations can present either with acute diarrhea, chronic diarrhea, recurrent diarrhea, or a persistent diarrhea based on the duration of illness. They can present with abdominal pain, which can be due to infections, due to malignancies, or due to hepatobiliary involvement. And as already mentioned, dysphagia and vaginophagia is quite common in children with HIV due to opportunistic infections with fungal, herpes simplex, and cytomegalovirus. And malabsorption is a frequent complaint in children with HIV due to infections per se or due to drugs or due to HIV enteropathy as well. And wasting is an important problem. And children can even present with GI bleed, which can be major bleed, a minor bleed, a recurrent bleed, or even presenting with unexplained anemia as well due to chronic GI blood loss. And jaundice can be due to liver involvement, can be due to biliary system involvement, which can be due to infections or due to drugs per se, and rarely due to malignancy. And the hepatobiliary disease objectives of a child with various GI and liver and biliary system should be focused on the various causes, the clinical manifestations, the symptoms, and the approach should be tailored based on the good history, thorough physical examination, and the investigations has to be ordered accordingly. The management should focus on the primary HIV infection plus the any infection that has been operating in the child apart from very good nutritional rehabilitation. So management becomes a mainstay of therapy in any child presenting with various GI and hepatobiliary disease in a child with retroviral infection. And as already mentioned, these children can present with oral cavity involvement, and most often these children will have feeding difficulty. They can interfere with the normal intake of food, affecting the quality of life due to malnutrition. And they can have dysphagia, weight loss as well. And infection forms an important part of any oral cavity involvement. The infections can be bacteria, they can be anaerobic infections, and fungal is the one which is quite common in children, and viral infections like cytomegalovirus, herpes simplex, and Epstein-Barr virus can cause the oral involvement. And malignancy like Kaposi sarcoma can involve the oral cavity. So in general, oral mucosa involvement can resulting in feeding difficulties, vomiting, and these can further jeopardize the nutrition status of a child with HIV infection per se. To name some of the oral lesions, one is oral leukoplakia, which can present due to Epstein-Barr viral infection. Most of these infections will be seen in children with immune suppression, which indicates a poor prognosis. The next infection is the one which can be seen in children is oral thrush. The most common organism is Candida albicans. Any child presenting with recurrent oropharyngeal candidiasis, one should always search for HIV infection in the child. A persistent or a recurrent oropharyngeal involvement beyond 8 weeks of life should have evaluated for an underlying HIV infection. Next is one, these children can present with stomatitis, gingivitis, which can be painful as well due to herpes simplex viral involvement. Necrotizing gingivitis, another bacterial infection that can occur in children with HIV. These can interfere with the feeding and oral intake of even solid food in older children. And after ulcers are known to occur in children with HIV, the cause of it is not known. However, these lesions can be painful, interfering with the normal intake of food in children with HIV infection. And lastly, the most aggressive form of malignancy is Kaposi sarcoma, which can also interfere with the various feeding habit of a child. So in a nutshell, these oral lesions can range from fungal infections, gingival stomatitis, oral hairy leukoplakia, after ulcers, and a malignant lesion. So oral cavity examination is a must in a child with HIV infection, even at the primary health center level by the primary caretaker of the child. So oral thrush, as mentioned, is caused by Candida albicans. Usually an uncomplicated disease can be treated with topical preparation with the clotrimazole, or if complicated, they may require oral fluconazole. The diagnosis is mainly made by clinical examination, plus the diagnosis can be established by the scrapings of the mucosa and stained with potassium hydroxide, which we can look for a budding yeast or a branching hyphae. This often indicates an immune suppression in a child with HIV. And oral leukoplakia is caused by Epstein-Barr virus infection. Usually it is a white plaquish lesion and no treatment is required. It indicates an immune suppression which heralds a bad prognosis in a child with HIV. And CM esophagitis can be characterized by recurrent vomiting, painful swallowing, or even dysphagia. They respond to ganciclovir, which I'll be dealing later. And herpes simplex can result in oral ulcers and as well as involving the esophagus. They respond to acyclovir either orally or IV preparation. And after ulcers, if painful, they can be treated with lidocaine, triamcinolone, or intra-additional prednisolone or colchicine. Kaposi sarcoma, though it is less common, but it can occur in children characterized by red or purple macules and the treatment usually by the antiviral agent. Once Kaposi sarcoma is present in a child, it indicates an aggressive form of the disease and indicates a bad prognosis. So oral cavity examination with a proper treatment is very essential in a child with HIV infection, more so when they are immunocompromised, the low CD4 count. And coming to the most common fungal infection in a child, it is Candida. Most often it can be due to Candida albicans or non-albicans species. These Candida can involve anywhere from the skin, oral cavity, from the gastric or even into the vagina. Oral thrush and diaper dermatitis are most commonly seen in children in 50 to 85% of HIV infected individuals. The most common predisposing factors are those on long-term antibiotic, malnourished, those on excessive smoking, especially in adolescents, they are prone to get this Candida infection, more so when the CD4 count is very low. And these lesions are characterized by creamy white precipitate which bleeds on scraping of the mucosa. Sometimes they can be characterized by patches or ascolitis. Diagnosis, as mentioned earlier, is mainly by scraping of the lesion and applying KOH preparation to look for budding yeast. And in case the child presents with the characteristic esophageal symptoms, endoscopy can be done to look for the typical lesions. But in any child with oropharyngeal candidosis presenting with dysphagia or odonophagia, esophageal involvement is more likely. This occurs in children most often co-infected with herpes simplex virus or cytomegalovirus. So, Candida infection is one of the most common fungal infections in any child with HIV. And coming to the most common symptom or important clinical condition is diarrhea. Children with HIV are more prone to develop diarrheal disorders, more so in country like us where infection is a problem. These diarrhea can be either acute diarrhea, that is passage of more than 3 loose stools per day lasting for more than 14 days. Acute dysentery, where the child will present with blood and mucus diarrhea, or the child can have duration of diarrhea beyond 14 days, what is called as persistent diarrhea or a chronic diarrhea. So many of the children, when they have a longer duration of diarrhea, they present with malabsorption symptoms due to fat malabsorption or even due to micronutrients malabsorption or carbohydrate malabsorption, which will further have an impact on the nutrition of a child. The mechanism of diarrhea in any child with HIV are many. To name some are the altered gut motility, decreased IgA, or decreased gastric secretions and altered gut motility. All these factors can predispose a child to have an opportunistic infection which is further confounded by a immune suppression resulting in diarrhea. So in general, diarrhea in a child with HIV can be due to infections, can be due to drugs, malignancy or intolerance, either a milk protein intolerance or any intolerance or allergy. Rarely, those children who are put on long-term antibiotics can have infection, toxin mediated diarrhea due to Clostridium difficile. So, diarrhea in a child with HIV, one should always get a detailed history on the duration, the type of diarrhea, that is small bowel, the large bowel, whether any associated malabsorption syndrome with good nutrition assessment. And we have to get the feeding habit of a child, the drug intake apart from constitutional symptoms to arrive at a possible etiology so that we can tailor the investigations accordingly. And what are the common pathogens in HIV infected children that can cause diarrhea? As I mentioned, diarrhea can be small bowel diarrhea or a large bowel diarrhea. Small bowel diarrhea is characterized by passing of large volume watery stools without blood and mucus. And the infections that are commonly associated are enteropathogenic E. coli, aggregative E. coli, non-typhoid salmonella, cryptosporidia, giardia, cytomegalovirus, cyclospora or the isospora. Whereas the bloody diarrhea is a one that is characterized by the passage of blood and mucus with urgency tenesmus, which is characteristic of colitis. These can be due to infections like Shigella, enterohemorrhagic E. coli, non-typhoid salmonella, or even a protozoal infection due to Entamoeba histolytica. Once again, here the history plays an important role to categorize as small bowel diarrhea or large bowel diarrhea so that to suspect an infective etiology as a cause of diarrhea based on the clinical symptoms and presentation. And what is the cause of chronic diarrhea? Many children with persistent diarrhea can have chronic diarrhea, especially when they are malnourished. Once again, the protozoal infections, as mentioned, like Cryptosporidia, Microspora, and Cyclospora, can result in chronic diarrhea. Bacteria like Shigella, Salmonella, Campylobacter, Clostridium, and Mycobacterium avium complex and enteropathogenic E. coli can cause chronic diarrhea. And viruses like rotavirus, especially more common in children less than 2 years, and other viruses being CMV, adenovirus, and HSV. And HIV per se can cause diarrhea, what is called as HIV enteropathy, which I shall be discussing later in detail. And how to approach child with diarrhea. As mentioned earlier, we should have a good clinical details including the type of diarrhea, blood and mucus with fever, vomiting, and macroscopic examination of stool is very important apart from stool microscopy and culture as when required. Sometimes we do have to resolve the child for endoscopy with a biopsy. Rarely the child may require even ultrasound and CT abdomen, especially when thinking of a tuberculosis, intestinal tuberculosis, lymphoma as a cause of diarrhea in any child. So good history forms a main part of approach to a child with diarrhea when they are infected with HIV infection. And how do you diagnose a child with diarrhea? I told based on the history and the physical examination, we should categorize whether they have dehydration or no dehydration and the nutrition status. And examination of stool is an important step in any child with diarrhea, and we should always send the sample on 3 consecutive days, and it should be very fresh because to improve the yield of an organism we need to send at least 3 consecutive samples. And sometimes we should do even a stool culture to look for the organisms like Shigella, even enterohemorrhagic E. coli, especially they need a phage typing. Campylobacter may require a stool culture. And we should not forget when they have very watery diarrhea or even presenting as colitis due to toxin mediated diarrhea, especially in a child who is on antibiotic for more than 2 to 3 months, in which case pseudomembranous colitis is an important cause of diarrhea in these children. And upper endoscopy with a small bowel biopsy is very important when they are not responding to conventional therapy or when the diarrhea is chronic and prolonged to establish the tissue diagnosis, especially even strongyloidosis, giardiasis can be diagnosed as an intestinal biopsy in a child with recurrent or a prolonged diarrhea. And this shows a simple stool test where we can find the giardia on a stool examination. Similarly, this slide shows the larval form of strongyloidosis which can occur with immune suppression where a child can present with recurrent infection or hyperinfection. This is an endoscopic biopsy from the duodenum showing the characteristic larva of strongyloids where the child would respond to therapy if identified and treated accordingly. More important is nutritional rehabilitation in a child with chronic or a recurrent diarrhea. And what the other stool tests we need to have in a child with diarrhea? Apart from stool microscopy to look for various organisms, and we have to do a stool for reducing substance when we are suspecting lactose intolerance. The child less than 2 years where they are fed with even artificial formula Sometimes we need to have a reduced substance, which is quite common due to carbohydrate malabsorption and fat malabsorption. We have to look for the stool fat. More than 100 per eye per field indicates significant fat malabsorption, which can occur due to liver disorders, small bowel disorders, hepatobiliary, or the pancreatic involvement. Often these children will have failure to thrive, stunted and wasting with fat malabsorption, and we can even estimate the stool alpha 1 antitrypsin due to when they present with hypoproteinemia or a condition called protein losing enteropathy. And the treatment, general treatment guidelines is for any other child. Always hydration forms a mainstay of management. Based on the hydration status, we have to treat the child accordingly, either with oral rehydration solution or with intravenous fluids. Child with severe diarrhea needs hospitalization and IV fluid administration. And zinc is an important element, should be given for all children with diarrhea. And children less than 6 months, we need to give 10 milligram, and for more than 6 months, 20 milligram of elemental zinc for 14 days. Especially zinc has been recommended by the IAP, it has been endorsed with WHO and UNICEF for all children with acute diarrheal disorders and even dysentery. Antibiotics, especially when you are suspecting infection, more so with blood and mucus diarrhea, where we have to give either oral antibiotics or intravenous antibiotic depending upon the general condition of the child. And nutritional rehabilitation should be done based on the age of the child, the custom in the family, as well as the economy of the child. And always when there is lactose malabsorption, we should start with low lactose diet, preferable should be with a home based diet, so that the child will recover with considerable weight gain on follow up. And this slide shows the various organisms like Shigella, Salmonella, Entamoeba, Cryptosporidia, Isosporias, as mentioned earlier, that can cause diarrhea. The clinical symptom of Salmonella will be having fever, blood and mucus diarrhea, and stool culture and Vidal and even blood culture is very, very essential. These children can be put on oral ciprofloxacin or IV ceftriaxone depending upon general condition. And Shigella is an important condition where the child can present with blood and mucus diarrhea. They respond to trimethoprim. Always the stool sample should be very fresh to identify the organism, and if resistant, you can add other antibiotics, even ciprofloxacin. Cryptosporidia can cause large watery stool, which I will be dealing later. Entamoeba can produce blood and mucus diarrhea. They respond to metronidazole. Isosporiasis respond to trimethoprim and sulfamethoxazole in divided doses. And giardia is very common in our country. They present with usually malabsorption, passing copious, foul smelling, greasy stool. And stool examination is a must look for OVA, and there is a history, trophocyte form, and metronidazole is an important drug for giardiasis. Microspora and Strangula. Microspora produces small bowel diarrhea. They respond to albendazole. Strongyloids, as mentioned, can cause diarrhea, hyperinfection syndrome. They can have other system involvement like ARDS, DIVC, or they can present with even protein-losing enteropathy. These children may require investigations like even a chest X-ray, stool microscopy, depending upon the clinical symptom. And they respond to albendazole or ivermectin. Albendazole for younger children, ivermectin can be used for older children. And hyperinfection has got a high fatality rate, especially when they are immunocompromised. And what is HIV enteropathy? I told the infection is an important cause of diarrhea in any child with HIV infection. But HIV enteropathy is a distinct entity which can occur in any child during the acute stage or even through chronic stage. The exact etiology is not known. It has been proposed that direct virotoxic effect on the enterocyte can cause HIV enteropathy. HIV has got an accessory protein called TAT protein, which interferes with the glucose uptake, and the HIV glycoprotein 120, it causes increased uptake of calcium, causing tubulin depolymerization of the epithelial cells. They cause ion imbalance and abnormal differentiation of enterocytes, resulting in what is called as HIV enteropathy. So HIV enteropathy, though the mechanism is not known, these are some of the mechanisms that do cause diarrhea in any child. Often this is characterized clinically by diarrhea and GI inflammation where they can present with anemia, weight loss, anorexia, and so on. And in general, HIV enteropathy is characterized by increased intestinal permeability. They have different malabsorption to micronutrients, more important being your bile acid malabsorption and vitamin B12 malabsorption. So this is a distinct entity apart from infection, which can be the cause of diarrhea in any child with HIV infection per se. And what is intestinal dysfunction syndrome? This is a syndrome in which child can have steatorrhea, carbohydrate malabsorption, where the child can present with abdominal bloating, distension, discomfort, or even passing frothy stools with perineal excoriation, or hypoproteinemia characterized by anasarca, ascites, or even iron malabsorption. But less commonly, intestinal permeability, reduced intestinal absorptive surface, and pancreatic dysfunction can actually contribute to what is called as a intestinal dysfunction syndrome. The most common is steatorrhea around 40%, followed by carbohydrate malabsorption in 35%, followed by iron malabsorption almost 45-50% of children. So these various manifestations put together, they are called as intestinal dysfunction syndrome, which can be operating in a single child and presenting as even weight loss, stunting, and malnutrition. And what is cause of growth failure? We all know HIV was called a slim disease in the past, and the children will be wasted, unstunted. And what are the causes of growth failure in a child with HIV? Is it always due to infection? It's not so. It is always a multifactorial etiology. And HIV itself can be the cause, or less of intake due to anorexia or to disease can result in negative nitrogen balance, or intestinal malabsorption can cause nutrient loss, once again a negative nitrogen balance, and immune impairment in a child with HIV can lead on to infection, a gut infection, extra gut infection, once again leading on to reduced caloric intake, and finally resulting in what is called as a failure to thrive condition in a child with HIV. So this is an important condition in HIV, peculiar to HIV, like any other illness, but it is more troublesome. At times it is even very difficult to manage in a child with HIV because the reasons are many. And cryptosporidiosis, I would like to mention once again, this is a common protozoan. It affects the small bowel as well as the large bowel, sometimes even biliary and the pancreatic system. Children with low CD4 count less than 100 per cubic millimeter are at high risk of your cryptosporidal infection. The mode of transmission is usually fecal-oral. Sometimes in adolescent with sexual promiscuity, oral intersex can be the reason, and the clinical symptom is characterized by watery diarrhea, abdominal pain, nausea, vomiting, weight loss, anorexia, and dehydration. As mentioned earlier, cryptosporidiosis can involve the liver, can cause biliary disease, and even pancreatitis. They can cause cholangitis due to biliary involvement. The child can present with obstructive jaundice or abdominal pain due to pancreatitis, or sclerosing cholangitis and papillary stenosis. All can result in abdominal pain, jaundice in a child with HIV. So cryptosporidiosis is an important infection which can affect the small bowel, the large bowel, and the extraintestinal sites in a child with HIV infection. The diagnosis is mainly by stool sample, which can detect the acid-fast organism, or we can even do a stool immunofluorescence study or by ELISA. Rarely, genotyping by PCR can be used to diagnose this condition, and endoscopy and colonoscopy with a biopsy with a conventional HND electron microscopy can detect this organism. And treatment, there is no effective, consistently treatment, antimicrobial treatment available as of now, but the Parmomycin, azithromycin, and etosanide are some of the drugs that has been used in children. And based on the age, we have to give 100 milligram twice a day for 3 days, and for more than 4 years, it is 200 milligram twice a day for 3 days. Those children who are not responding can be put on azithromycin at a dose of 10 milligram per kg on day 1, then 5 milligram per kg for 2 to 10 days orally. And important is nutrition supplementation along with antiretroviral therapy. Children with a CD4 count of more than 100 will have a better prognosis, and personal hygiene is very important to prevent this infection in children. or infected with HIV. Boiling, cleaning the vegetables, and also improving the sanitation, personal hygiene play an important role in the prevention of diarrhea due to this organism. Dysosporiasis, as mentioned earlier, it is a protozoa which can cause small bowel diarrhea characterized by watery diarrhea, abdominal discomfort, pain at times, or malabsorption. These children will have weight loss, anorexia, they can have chronic diarrhea as well. Once again, the mode of transmission is fecal oral. In those children with CD4 count less than 150, they are at high risk. Often this infection result in severe prolonged diarrhea. And diagnosis is by stool microscopy with unstained wet mount preparation took for oocyst or by an endoscopic biopsy. And the treatment is with trimethoprim and sulfamethoxazole at a dose of 20 mg per kg per day in 4 divided doses for 10 days, then twice a day for 3 days. Once again, improving the personal hygiene play an important role in the prevention of this infection. And CME infection is another opportunistic infection that is known to cause disease in children infected with HIV. Almost it can cause disease 8 to 10% of cases, and it can involve the esophagus, resulting in dysphagia, vaginophagia, feeding difficulties, retrostomal pain, or even GI bleed. Ulcers are often large and deep ulcers which are distributed along the one third of esophagus at the lower end, usually by CME infections. They can also involve the large bowel, causing blood and mucus diarrhea, tenesmus, urgency, and colonoscopy in these children will show aphthous ulcers, even ulcers mimicking an inflammatory bowel disease or a pseudo polyposis like syndrome. This is an endoscopic picture showing multiple linear areas of erythema with ulcers distributed along the circumference of the esophagus, which is due to CMV esophagitis. And this is a colonoscopic image showing a loss of vascular pattern, the shiny mucosa, edema, erythema, friability with ulcers typical of CMV colitis. And biopsy of this lesion will show the typical owl eye inclusion bodies. This is a characteristic owl eye inclusion bodies. It can occur intracytoplasmic and intranuclear, called as owl eye inclusion bodies, characteristic of a CMV infection. And as mentioned, herpes simplex, another common opportunistic infection in children. These herpes simplex infection can be during co-infection from the mother, or can occur the perinatal period or even postpartum, and they can cause various lesions involving the oral cavity like stomatitis, esophagitis, gingivitis, and liver involvement. And clinical symptoms characterized by small, multiple, painful mucocutaneous lesions on a red base. And biopsy or the culture may show the characteristic Zang cells on histopathology. And this is the endoscopic view showing shallow ulcers unlike CMV. This is typical of a HSV infection. However, biopsy is the final court of appeal to establish the diagnosis by histopathology. And the treatment for CMV can be IV ganciclovir at the dose of 5 mg per kg per dose twice a day or 1 to 2 hours for 2 to 3 weeks. In those who are resistant to ganciclovir, can be given foscarnet 60 mg per kg per dose every 8 hours for 2 to 3 weeks. For HSV infection, either oral or IV acyclovir, depending upon the underlying clinical condition, for a period of 7 to 14 days is advisable. And GI bleed. GI bleed is another important GI manifestation in children with HIV infection. Most often the cause can be non-infectious or infections like Salmonella, Shigella, Campylobacter, Mycobacteria, cytomegalovirus, and even penicillosis. They can cause mucosal ulcers resulting in GI bleed. GI bleed can occur due to one distinct entity in children with HIV, what is called as diffuse infiltrative lymphocytosis syndrome. These children can present with unexplained anemia, or most of our occult blood being positivity, or even frank hematemesis or melena. So endoscopy with a biopsy will give you the clue. The most common site of GI bleed is from the esophagus or from the colon. From the esophagus, they present as either hematemesis or melena. From the colon, either as a frank hematochezia or just knuckle GI blood loss. And the most common mechanism causing these bleed are due to vasculitis secondary to endothelial damage resulting in ischemia, necrosis, and thrombosis. So they can have even a painful bleed. And the primary infection of the gut epithelial cell due to infection can be the cause apart from your vasculitis. So GA bleed is another important clinical manifestation of children with HIV. And tuberculosis, as we all know, tuberculosis is endemic in our country, and from the extra pulmonary site can be either your CNS, bone, or even a serous involvement. Child with GI tuberculosis can present either with ascites due to serous involvement, or they can present just as a nodal mass, or they can present with luminal involvement, presenting with diarrhea, small blood type of diarrhea, or when they have tuberculous colitis, rarely they can present with blood and mucus diarrhea, or they can present with proteinous enteropathic condition, malabsorption, and so on. Finally, constitutional symptoms like fever, weight loss, anorexia with various GI involvement. One should always keep tuberculosis as a possibility, and acidic fluid analysis, if present, will help, especially in those with acidic form of tuberculosis. And colonoscopy with terminal ileoscopy is a must in a child who is presenting with mucous involvement, and CT may give other additional information in a child with GI tuberculosis. Children with GI tuberculosis need treatment with 6 months of ATT to have a good recovery. This is just to show a colonoscopy view of the ileum showing multiple nodules which can be seen in tuberculosis, and sometimes imaging studies can pick up space occupying lesions in liver. Sometimes they can pick up some of the nodes or even a thickening of the bowel wall or even a ascites, in which case we have to keep tuberculosis as a possibility apart from lymphoma, especially non-Hodgkin's lymphoma can also present with organ involvement with luminal involvement. So imaging studies may be of help in a case of suspected GI tuberculosis, especially to keep a differential diagnosis of even a malignancy. But ultimate is a biopsy which will pick up the cause of finding in these children with HIV infection. And GI malignancy in children is often due to constant lymphostimulation due to lack of effective human surveillance. The most common GI malignancy are non-Hodgkin's lymphoma and Kaposi sarcoma. When to suspect GI malignancy in a child with HIV? Any child presenting with fever, weight loss, diarrhea, organomegaly, jaundice, abdominal distension, or a GI bleed. Apart from infections, we should always suspect a malignancy in the child so that we can plan the investigations and do appropriate therapy. And mesenteric adenopathy, in general, this is a common occurrence in any child when they come with an ultrasound finding. Generally, primary mesenteric lymph nodes for a normal child or even any diseased child is defined as right-sided mesenteric nodes without any identifiable acute inflammatory process or with mild less than 5 mm thickening of the terminal ileum. And nodes more than 3 in number or size more than 8 mm along its long axis. In general, in Indian scenario, when the nodal size is more than 14 mm along its long axis, number more than 5, we should always look for other causes. But a clinical history and a thorough physical examination is very important. The nodes are said to be primary when there are no identifiable organic pathology. Nodes are said to be secondary when another pathology is identified, like bowel wall thickening, ascites, other group of nodal involvement, when we can suspect tuberculosis, even a lymphoma in the child. This is just to show the anatomy of the mesenteric node. There are about more than 300 group of nodes, 300 number distributed along the mesentery, along the blood vessels. And mesenteric nodes can be just a non-specific finding when the child is alright. But a child with HIV infection, when they present with constitutional symptom, we should always think of infections, and the most common infection that has been now reported is penicillosis. Apart from tuberculosis, Yersinia, lymphoma can result in mesenteric nodes in a child with HIV. As mentioned earlier, any child presenting with mesenteric nodes, the nodal size is very important, the number of nodes should be given importance, and the altered echoes of the nodes, whether it is hypoechoic, hyperechoic, or associated clinical symptom should be taken care of. A child with penicillosis can present with acute abdomen, they can present just as acute appendicitis, perforation, or even fever with rash. Biochemically, penicillosis can be characterized by elevated alkaline phosphatase. This is the intracellular fungi, dimorphic fungi, which can be diagnosed from the bone marrow or from the lymph node, sometimes even from the tissue biopsy. And treatment is by IV amphotericin B, 0.6 mg per kg per day for 2 weeks, followed by oral itraconazole, 2 to 5 mg per kg per day for 10 weeks. This is seen in patients with very high viral load and low CD4 count. And coming to the next part of the discussion is on liver and spleen involvement. In general, liver and spleen involvement in a child with HIV can be due to infections as mentioned earlier, or they can be due to an unexplained cause which comes under the clinical stage 2 of HIV infection. Sometimes liver can be involved due to hepatotrophic virus, non-hepatotrophic viruses, or due to drug-induced liver injury can be the cause of a liver and spleen involvement. Granulomas may be the cause, and malignancy, which can result in organomegaly, especially the liver and spleen. Liver in HIV, 90% of children will have hepatosplenomegaly. Most often, any infection in children can have an hepatomegaly or splenomegaly, but we should always keep the possibility of any infection, tuberculosis, lymphomas, and any viral hepatitis, either acute or chronic, as a cause of your liver involvement in children. As mentioned earlier, infection play an important role. Never forget the drugs. Drugs like your pentamidine, fluconazole, anti-tuberculous drug, and even antiretroviral DDT, they can cause drug-induced liver injury. So, drug-induced liver injury is an important cause of liver involvement apart from infections. And malnutrition per se can cause a liver involvement due to fatty liver. The clinical presentation of hepatomegaly or splenomegaly can be an unexplained organomegaly. They can just present with jaundice, acute hepatitis, chronic hepatitis, or presenting with hepatocellular jaundice with high colored urine with or pale stools. Some of them can even have obstructive jaundice where they can have fever, right quadrant pain, high colored urine, pale stools, sometimes even itching. And biochemically, elevated transaminase, one should always keep a possibility of, especially alkaline phosphatase, should think of an obstructive jaundice. However, this can occur with drug-induced liver injury or even an infiltrated disorders like a granulomas or even a malignancy. In general, sometimes the clinical findings may be very difficult to categorize into the etiology, but at times may be atypical as well. But high index of suspicion, a good history is always essential in arriving at the diagnosis of the cause of liver and spleen involvement in a child with HIV infection. And among the infections, Mycobacterium tuberculosis, cryptosporidiasis, herpes simplex, cytomegaloviral infections, pneumocystis carinii, microspora, salmonella can cause organomegaly, hepatobiliary diseases, and HIV per se can cause hepatobiliary involvement. And non-Hodgkin's lymphoma and Kaposi sarcoma are two important malignancies where the child can have liver and spleen involvement presenting clinically. And viral hepatitis, HIV. Viral hepatitis can be due to hepatotrophic virus like A, E, B or C, or due to non-hepatotrophic virus like HSV, CMV, or even HIV virus per se. Those children with increased sexual promiscuity or IV drug abuse, they can have transmission of B and C infection. However, perinatal transmission of B and C can occur in children along with HIV when they are co-infected. So, increased risk of chronic hepatitis B and C and D is known to occur in children with either co-infection or when they're transfused with multiple blood and blood products or even an organ transplant. Hepatitis can be acute hepatitis, it can be infective hepatitis or drug-induced liver injury presenting as hepatitis or biliary pathology causing jaundice. And chronic hepatitis as mentioned earlier due to BNC and majority are asymptomatic. Some of them will present as acute hepatitis like picture, but chronicity is a known fact and with a smoldering effect. They can even lead on to cirrhosis, end-stage liver disease. Sometimes these children can present with acute serum sickness like picture with arthralgia, rash, bone pain, fever and jaundice. Hepatitis B, majority of the infections are asymptomatic. Acute illness can be a presenting feature in some, but persistent smoldering infection can occur in children who are co-infected and clinically they can manifest or present as hepatomegaly, splenomegaly, with or without ascites and jaundice. Extrahepatic manifestations like skin lesions, arthropathy, bone marrow depression, polyarthritis nodosa and nephritis can be a presenting feature. Diagnosis mainly by serology, detection of HbSAg in the blood, and if anti-HbC IgM type is found, it indicates acute infection, but may not be detected in perinatally acquired disease. And elevated transaminases, if present, indicates there is a hepatocellular damage, which is a surrogate marker of your immune-mediated damage due to hepatitis B. All children with hepatitis B infection should be vaccinated against hepatitis A to prevent superadded A causing fulminant liver failure or acute liver failure, which can result in death of a child. Indications for treatment as mentioned earlier, presence of HbSAg for more than 6 months and high viral load, elevated transaminases at least more than twice the upper limit of normal with or without chronic hepatitis picture on a biopsy. These children need treatment with lamivudine, interferon, but however interferon is contraindicated in those children with decompensated liver disease. If lamivudine are used as a monotherapy, the dose should be very high, 4 mg per kg, but maximum 150 mg per day. And coming to the co-infection or a perinatally acquired infection or infection through blood products, hepatitis C is another viral hepatitis that can have an impact on the natural history of HIV infection in children. The mode, as mentioned, can be due to blood products transfusion or even vertical transmission, and it often results in a benign course. The disease is usually slow, but however can be just presenting with fluctuating SUOT and SGPT alone. Liver biopsy may show fatty chain, portal lymphoid aggregates and fibrosis. And diagnosis is made by detection of HCV RNA by PCR with a liver biopsy. All children should be tested for HCV infection when they are with HIV. And more important, anemia. Anemia is common in children with hepatitis C infection. This potentiates the toxicity, and even ribavirin when used should be used very cautiously. And more important, when interferon is being used, the sustained response to antiviral agent is less, 15 to 20% less when compared to controls. Hepatitis C infection, the virus accelerates a natural history of HIV infection, so slow progression to cirrhosis and even end-stage liver disease or sometimes even hepatocellular carcinoma. And the duration of therapy depends on the genotype. In genotype 1, the duration is longer, even requiring 48 weeks. But for other types, 24 weeks of antiviral therapy is recommended. However, interferon is contraindicated in decompensated liver disease when they present with encephalopathy and they present with ascites. In such children, interferon cannot be used as an antiviral agent. And coming to the vaccine, hepatitis A vaccine should be given to all children above the age of 1 year in those infected with the hepatitis C virus. And interferon alpha 2A or 2B can be used plus ribavirin. as an antiviral agent. Dose of interferon is 3 to 5 microunits per meter squared thrice weekly. It should be given subcutaneously. Ribavirin is generally used for children above the age of 3 years, and for genotype 1, as mentioned earlier, it is 48 weeks. But however, if there is no response by 12 weeks of interferon therapy, it has to be stopped because the response may not be as expected. And for genotype 2 and 3, 6 months regimen or a 24 weeks regimen with interferon and ribavirin is advised. Sclerosing cholangitis, this is another important condition seen in around 20% of children. Often it is due to CMV and cryptosporidal infection. Associated with sclerosing cholangitis, they can have papillitis, acalculous cholecystitis, or a stone in the common bile duct. These children can present with abdominal pain, right upper quadrant pain, jaundice, high colored urine, pale stools, itching, anorexia, or even just presenting with elevated alkaline phosphatase or even SGOT-PT. And whenever a child presents with suspected obstructive jaundice, and if on imaging there is intrahepatic biliary radicus dilatation, next step should be to subject the child for a endoscopic retrograde cholangiopancreatography, which can be both diagnostic and therapeutic in children with biliary obstruction. And this is a picture of ERCP. This is side wing scopy, which on injection of dye there is irregularity of the biliary system. This is the common bile duct, this is a right hepatic duct, this is a left hepatic duct showing beaded appearance, which is typical of a sclerosing cholangitis, which is quite common in children with HIV infection. And a biopsy of the tissue can show a typical onion skin appearance, which is suggestive of a sclerosing cholangitis. And in general, histopathology, examination of liver in a child with HIV can vary from various array of findings like giant cell transformation due to infections and malignancy, sometimes with steatosis due to malnutrition or to drugs, portal inflammation, once again may be due to either vascular or due to drug-induced liver injury, pericentral necrosis due to infections, granulomas either due to tuberculosis or due to drugs, or rarely a malignancy like picture. So liver histology can show array of findings in a child with HIV infection, and the cause can be anything from infection to non-infectious etiology. This is a histological finding of a liver biopsy showing a large granuloma. In general, granulomas can be due to tuberculosis, sometimes due to fungal, drugs, and malignant infiltration, and can show a granulomatous lesion. Caseation may or may not be there in a child with suspected tuberculosis when they are immunosuppressed, and in general, elevated SAP indicates either an infiltrated lesion or a granuloma. The treatment depends upon the underlying etiology because granuloma is a finding on a liver biopsy. The cause can be anything. So I would like to conclude my talk by telling children with HIV are at risk of GI, liver and biliary involvement. And more than one organ may be involved in the same child. Most often the causes are infectious. However, non-infectious etiology may predominate in a child, and more than one organism can cause a disease in the same child, and symptoms may be typical, subclinical or atypical or even clinically silent. However, high index of suspicion is very essential. Hence, a good history, thorough physical examination, including a nutrition assessment, is very essential in a child with HIV infection when they present with various GI and hepatobiliary disease. And appropriate therapy along with highly active antiretroviral therapy is essential in a child with GI manifestations or hepatobiliary manifestations. And last but not the least is a nutrition. Any child with HIV needs nutrition rehabilitation. So this forms an integral part of management in a child with various disorders when they are infected with HIV. Thank you. Once again, I thank ITech India, NACO, and Pediatric Center of Excellence for giving me the opportunity.
Thank you so much, madam. Participate down any queries have in the in the chat box, you can see on the right side of the window. And they're also requested to please vote on this e-poll you can see on the left side of the window.
Okay. The questions for the answers may be posted either shortly if it is available now, or any reference if I need may require a few, at least 1 or 2 days for me to get clarification, and I'll let you know all the answers through the web link.
Thank you so much, ma'am. It was indeed a very good presentation. Recorded link and the presentation would be circulated to you all shortly. Thank you so much for participating in NDLS series. Thank you all.